Hi, it's Merrina again. Welcome back to reading another chapter of Better by Atul Gawande with me. So last time we read chapter 3, which talked about casualties in the wars of Iraq and Afghanistan and how efficient trauma surgeons were at treating their patients and making sure that they can survive instead of die from the serious injuries. And today we're starting chapter 4, which is called Naked. I'm not sure what it means, but let's keep reading to find out. There is an exquisite and fascinating scene in Kandahar, the 2001 movie set in Afghanistan under the Taliban regime, in which a male physician is asked to examine a female patient. They are separated by a dark blanket-like screen hung between them. Behind it, the woman is covered from head to foot by her burqa. The two do not talk directly to each other. The patient's young son, he looks to be about 6 years old, serves as the go-between. She has a stomachache, he says. Does she throw up her food? The doctor asked. Do you throw up the food? The boy asks. No, the woman says. Perfectly audible, but the doctor waits as if he has not heard. No, the boy tells him. For the purpose of examination, there is a 2-inch circle cut in the screen. Tell her to come closer, the doctor says. The boy does. She brings her mouth to the opening, and through it he looks inside. Have her bring her eye to the hole, he says, and so the exam goes. Such, apparently, can be the demand of this decency. This part is very interesting to me because as a girl with no religion, I have never thought that medical care could be done in this way. You literally need a family member to pass along the words, even though the woman and the doctor are just separated by a screen. But I guess people have to do certain things like that due to their religious beliefs. And as future healthcare workers, we need to be mindful of what people need and try to accommodate to our best. When I started my surgical practice, I was not at all clear what my etiquette of examination should be. There are no clear standards in the United States. Expectations are murky, and the topic can be fraught with hazards. Physical examination is deeply intimate, and the way a doctor deals with the naked body, particularly when the doctor is male and the patient is female, inevitably raises questions of propriety and trust. No one seems to have discovered the ideal approach. An Iraqi surgeon told me about the customs of physical examination in his home country. He said he feels no hesitation about examining female patients completely when necessary, but because a doctor and a patient of an opposite sex cannot be alone without eyebrows being raised, a family member will always accompany them for the exam. Women do not remove their clothes or change into a gown. Instead, only a small portion of the body is uncovered at one time. A nurse, he said, is rarely asked to chaperone. If the doctor is female, it is not necessary, and if it's male, the family is there to ensure that nothing unseemly happens. In Caracas, according to a Venezuelan doctor I met, female patients virtually always have a chaperone for a breast or pelvic exam, whether the physician is male or female. That way, there are no mixed messages, the doctor said. The chaperone, however, must be a medical professional, so the family is sent out of the examination room and the female nurse brought in. If a chaperone is unavailable or the patient refuses to allow one, the exam is not done. A Ukrainian internist from Kiev told me that she has not heard of doctors there using a chaperone. I had to explain to her what a chaperone was. If a family member is present at an office visit, she said, he or she will be asked to leave. Both patient and the doctor wear their uniform forms. If the patient a white examining gown, the doctor a white coat. Last names are always used. There is no effort at informality to muddy the occasion. These practices, she believes, are enough to solidify trust and preclude misinterpretation of the conduct of care. A doctor, it appears, has a range of options. This is interesting looking at how different countries treat female patients differently. For me, I think I would be more comfortable seeing a female physician than a male physician, but I think that for many other women, it might not be as comfortable, especially when they're talking about like gynecology related issues. In October 2003, I posted my clinic hours, and soon my first patients arrived to see me. For the first time, I realized I was genuinely alone with patients. No attending physician supervising in the room or getting ready to come in. No bustle of emergency room personnel on the other side of a curtain. Just a patient and me. We'd sit down, we'd talk. I'd ask about whatever had occasioned the visit, about past medical problems, medications, the family and social history. Then the time would come to have a look. There were, I would admit, some inelegant moments. I had an instinctive aversion to examination gowns. At our clinic, they are made of either thin, ill-fitting cloth or thin, ill-fitting paper. They seemed designed to leave patients exposed and cold. I decided to examine my patients while they were in their street clothes, for the sake of dignity. If a patient with gallstones wore a shirt she could untuck for the abdominal exam, this worked fine. But then I'd encounter a patient in tights and a dress, and the next thing I knew, I had her dress buttoned up around her neck, her tights around her knees, and both of us wondering what the hell was going on. An exam for a breast lump one could manage in theory. A woman would unhook her brassiere and lift or unbutton her shirt. But in practice, it just seemed weird. Even checking pulses would be a problem. Pant legs could not be pushed up high enough to check a femoral pulse. The femoral artery is felt at the crease of the groin. Try pulling them down over shoes, however, and forget it. I finally began to have patients change into the damn gowns. I haven't, however, asked men to do so nearly as often as women. I asked a female urologist friend of mine whether she had her male patients change into a gown for a genital or rectal exam. No, she said. Both of us just have them unzip and drop. As for having a chaperone present with female patients, I hadn't settled on a firm policy. I found that I always asked a medical assistant to come in for pelvic exams and generally didn't for breast exams. I was completely inconsistent about rectal exams. I surveyed my colleagues about what they would do and received a variety of answers. Many said they bring in a chaperone for all pelvic and rectal exams, anything below the waist, but only rarely for breast exams. Others have a chaperone for breast and pelvic exams, but not for rectal exams. Some do not have a chaperone at all. Indeed, an obstetrician gynecologist I talked to estimated that about half the male physicians in her department do not regularly use a chaperone. He himself detests the word chaperone because it implies that mistrust is warranted, but he often brings in an assistant for pelvic and breast exam. Few of his patients, however, find the presence of the assistant necessary after the first exam, he said. If the patient prefers to have her sister boyfriend or mother stay for the exam, he does not object. But he is under no illusion that family chaperone offers protection against an accusation of misconduct. Instead, he relies on his reading of a patient to determine whether bringing in a nurse witness would be wise. One of our residents, who was trained partly in London, said he found the selectivity here strange. In Britain, I would never examine a woman's abdomen without a nurse present. But in the emergency room here, when I asked to have a nurse come in when I needed to do a rectal exam or check groin nodes on a woman, they thought I was crazy. Just go in there and do it, they said. But in England, he said, if you need to do a breast or rectal exam or even check femoral pulses, especially on a young woman, you would be either foolish or stupid to do it without a chaperone. It doesn't take much, just one patient complaining. I came in with a foot pain and the doctor started diving around my groin, and you could get suspended for a sexual harassment investigation. Britain's standards are stringent. At General Medical Council, the Royal College of Physicians, and the Royal College of Obstetricians and Gynecologists specify that a chaperone of the appropriate gender must be offered to all patients who undergo an intimate examination, that is, involving the breast, genitalia, or rectum, irrespective of the gender of the patient or of the doctor. A chaperone must be present when a male physician performs an intimate examination of a female patient. The chaperone should be a female member of the medical team, and her name should be recorded in the notes. If the patient refuses a chaperone, an examination is not urgent. It is supposed to be deferred until it can be performed by a female physician. This is really weird. In Britain, you have to have a female chaperone when a male physician wants to do anything with a female patient. That I feel like it is safer for the female patients, but at the same time, it seems to imply that women are at risk of sexual harassment by doctors who we're supposed to trust. And I think that this policy isn't in place in the United States because it is time-consuming and it takes away a nurse's time from her to do other works just so she can make sure that the female patient isn't harassed. So it's a tricky decision to make, I think. In the United States, where we have no such guidelines, our patients have little idea of what to expect from us. To be sure, some minimal standards had been established. The Federation of State Medical Boards had spelled out that touching a patient's breasts or genitalia for a purpose other than medical care is a sexual violation and disciplinable offense. So are oral contact with the patient, encouraging a patient to masturbate in one's presence, and providing services in exchange for sexual favors. Sexual impropriety, which involves no touching but is no less prescribed, includes asking a patient for a date, criticizing a patient's sexual orientation, making sexual comments about a patient's body or clothing, or initiating discussion of one's own sexual interests or fantasies. I cannot say anyone taught me these boundaries in medical school, but I would like to think that no one needed to teach them. This part reminded me of the USA gymnastics scandal where the doctor has harassed many girls over the years, and he wasn't really punished until a bunch of those girls came out and said that he did a lot of unnecessary things with their bodies. So stuff like that do happen, and we do need to be mindful to protect female patients. The difficulty for doctors who behave properly is that medical exams remain inherently ambiguous. Any patient can be led to wonder, did the doctor really need to touch me there? And when doctors simply inquire about a patient's sexual history, can anyone be certain of the intent? The fact that all medical professionals have blushed or found their thoughts straying in unwanted directions during a patient visit reveals the potential for impropriety. The tone of an office visit can turn on a single word, a joke, a comment about a tattoo in an unexpected place. One surgeon told me of a young patient who expressed concern about a lump in her boob, but when he used the same word in response, she became extremely uncomfortable and later made a complaint. A woman I know left her gynecologist after he let slip an offhand admiring comment about her tan lines during a pelvic exam. The examination itself, the how and where of the touching, is, of course, the most potentially dicey territory. If a patient even begins to doubt the propriety of what a doctor is doing, something must not be right. So, what then should our customs be? There are many reasons to consider setting higher, more uniform professional standards. One is to protect patients from harm. About 4% of the disciplinary orders that state medical boards issue against physicians are for sex-related offenses. 1 of every 200 physicians is disciplined for sexual misconduct when patients, sometimes during his or her career. Some of these cases have involved such outrageous acts, such as having intercourse with patients during pelvic exams. The vast majority of cases involved male physicians and female patients, and virtually all occurred without a chaperone present. In one state, about a third of cases involved dating patients or sexual touching of them. 2/3 involved sexual impropriety and inappropriate touching, short of sexual contact. This part further confirms that what the British Medical Board has its reasons. Like if you do not provide a chaperone when a male physician is examining a female patient, improper stuff might actually happen. So just to be on the safe side, maybe the United States should do what the British people do to make sure that there has to be a chaperone. Otherwise, the examination can't happen. Clearer standards could also reduce false accusations against physicians. Chaperones, in particular, provide physicians with a stronger defense when such accusations are made. Inappropriate patient behavior might be averted too. And a 1994 study found that 72% of female medical students and 22% of male medical students experienced at least one instance of patient-initiated sexual behavior. 12% of the females were sexually touched or grabbed by patients. Yet, all this said, eliminating misconduct and accusations seemed like the wrong priority to drive how doctors proceed when examining patients' bodies. The trouble is not that problems are rare, though the statistics suggest they are, or that total prevention of impropriety, zero tolerance, is impossible. It is that the measures required to achieve total prevention inevitably approach the Taliban and I don't know what this word means, and risk harming patients by discouraging complete and thorough examinations. Instead, the most important reason to consider tightening standards of medical protocols is simply to improve trust and understanding between patients and doctors. The new informality of medicine, with white coats disappearing, and patient and doctor sometimes on first-name basis, has blurred boundaries that once guided us. If physicians are unsure about what the etiquette of the examination room should be, is it any surprise that patients are too, or that misinterpretations occur? We have jettisoned our old customs, but we have not managed to replace them. My father, a urologist, has thought carefully about how to avert such uncertainties. From the start, he told me, he felt the fragility of his standing as an outsider, an Indian immigrant practicing in our small southern Ohio town. In the absence of guidelines to reassure patients that what he does as a urologist is routine, he made painstaking efforts to avoid any questions. The process begins before the examination. He always arrives in a tie and a white coat. He is courtly, although he often knows patients socially and doesn't hesitate to speak to them about private matters. The subjects can range from impotence to sexual affairs. He keeps his language strictly medical. If a female patient must put on a gown, he steps out while she undresses. He makes a point of explaining what he was going to do during an examination and why. If the patient lies down and needs further unzipping and unbuttoning, he is careful not to help. He wears gloves, and even for abdominal examinations. If the patient is female and under 18 years of age, he brings in a female nurse as a chaperone, whether the examination is intimate or not. His approach works. He has a busy practice. There have been no seemingly rumors. I grew up knowing many of his patients, and they seem to trust him completely. I find, however, that some of his practices are not quite right for me. My patients are as likely to have problems above the waist and below, and having a chaperone present for a routine abdominal exam or an examination of enlarged lymph nodes under an arm seemed absurd to me. I don't don gloves for non-genital exams either. Nonetheless, I have tried to emulate the spirits of my father's visits, the decorum in language and attire, the respect for modesty, the precision of examination. As I thought further about his example, I made changes. I now routinely bring in a female assistant, not just for pelvic exams, but also for female breast and rectal exams. If it's all right, I'll go get Janice, I said. She can be our chaperone. It is unsettling to find how little it takes to defeat success in medicine. You come as a professional, equipped with expertise and technology. You do not imagine that a mere matter of etiquette could foil you, but the social dimensions turned out to be as essential as the scientific. Matters of how casual you should be, how formal, how reticent, and how forthright. Also, how apologetic, how self-confident, how money-minded. In this work against sickness, we begin not with genetic or cellular interactions, but with human ones. They are what makes medicine so complex and fascinating. How each interaction is negotiated can determine whether a doctor is trusted, whether a patient is hurt, whether the right diagnosis is made, the right treatment given. But in this realm, there are no perfect formulas. Consider my chaperone solution, for example. A Manhattan friend in her 30s told me about seeing a dermatologist because of a mole she was worried about. The doctor was in his 60s and perfectly professional. When it came time for him to examine the mole and to check whether she had other under her threadbare examination gown, he brought a chaperone. This was, in theory, for her comfort and reassurance, but the chaperone, a female aide who stood watching as the dermatologist examined my friend's body, only made her feel more conspicuously on display. It was awkward, my friend told me. The very idea of a chaperone seems to shout, "This is a highly charged situation," and in order to avoid a possible he said, she said litigation, this nurse is going to stand silently and pointlessly in the corner. It makes me feel more self-conscious and takes the weirdness level up to a DEFCON 5. I felt like it turned a routine physical into a silent Victorian melodrama. This is very interesting because a lot of the times when physicians do certain things, they are thinking what benefits it has to them, but the patients also have complex feelings as well. And I certainly agree that some female patients would feel uncomfortable to have multiple people in the room just staring at her when she is partially naked or anything like that. So, do male physicians make women more comfortable with intimate examinations involving a chaperone or not? My bet is that bringing an aide it helps more than it hurts. But we don't know. The study has never been done, and that itself is evidence of how much we have underestimated the importance and difficulty of human interactions in medicine. Everything from etiquette to economics, from anger to ethics, can work its way into a seemingly routine office appointment. The relationships are deeply personal, involving promises and trust and hope. And this is what makes doing well as a clinician more than a matter of outcomes and statistics. One must also do right. How to do right by patients can be uncertain, sometimes overwhelming so. Do you bring in a chaperone or not? If, on your examination, you find a mole and think it's worrisome, but a second opinion disagrees, do you reconsider your diagnosis or not? If you've tried several treatments and they fail, do you keep fighting or do you stop? Choices must be made. No choice will always be right. There are ways, however, to make our choice better. I really enjoy reading this chapter because it brings me to the issues surrounding female patients being seen by male doctors, and I enjoyed reading about his perspectives and what other physicians have done, and I think it's something that we should continue to think about when we strive to provide the best quality care to all sorts of patients regarding their gender, regarding their comfortableness with doctors and other people being in the room. So we will see you in the next chapter. Thank you for being with me.